So thank you, Dr. Clark, for giving up your time and expertise today to answer some questions on female fertility in recognition of World Fertility Day. The questions were posted to FAST's Facebook page by our followers, and I know your input will mean a lot to them. Please can you start off by telling us a little bit about yourself and Medfem Fertility Clinic, where you're situated, etc.
Well, firstly, thank you very much for asking me. My name is Dr. Nick Clark. I'm from Medfem Clinic. It's a fertility clinic that is based in Bryanston, Johannesburg. There are 3 specialists. We pretty much cover all aspects of in vitro fertilization, assisted reproduction, and any fertility related issues. We've been doing this for a very long time. The clinic's been around for probably 30 or more years. And so we have a vast combined experience in pretty much all aspects of fertility, and we're proud to help people and try and achieve the very best we can for them.
Excellent, thank you. Okay, let's go straight into the questions then. Number 1, do you always get symptoms when you have endometriosis, or could you have it without even knowing?
Yeah, this is a very good question. The answer is that endometriosis as a whole is actually a very common background condition. Something like 15% of women in their fertile years may have endometriosis. And in reality, the vast majority will have no symptoms. They won't even know that they have it. So the symptomatic patients form a smaller percentage of the overall numbers. And the same with fertility. There are people who have fertility issues and no symptoms. There are people who have symptoms with no fertility issues. There are people who have symptoms and fertility issues. It's quite a wide spectrum, and it is a fluctuating disorder. So it can exist with a level of severity at one point in time, and that changes related to many factors, which we won't go into now, but that mean that it's not a sort of a necessarily progressive or static condition.
Great. And how do you diagnose endometriosis?
This is more difficult because the diagnosis of endometriosis primarily at this stage is a surgical diagnosis. So what happens normally is one would build up a level of suspicion. So you risk profile. So for example, somebody who has struggled to fall pregnant, so they've presented to a fertility clinic and then they report that they have pain with their periods. With just those 2 pieces of information, there's about a 30 to 50% chance that you might pick up endometriosis if you were to look for it. So we risk profile, and then to make a firm diagnosis, the commonest way would be to perform a surgical procedure, which is known as a laparoscopy or endoscopy, where you put a tiny little camera into the umbilicus and you look into the pelvis and you visually diagnose it. There are, however, some markers that have become available and commercialized into a testing kit. And I think more and more we will use markers, not so much to diagnose the condition, but to diagnose the condition where it's significant. So people who express certain chemical markers may be the group we're interested in, for example, for fertility. So the biochemical side, although not the mainstream at this point in time, is a very interesting developing area.
Thank you. Okay, and then we move on to PCOS, so polycystic ovary syndrome. Is it a hormonal condition?
Yeah, so primarily it is a hormonal condition. One of the problems with polycystic ovarian syndrome is that it's really a misnomer. The idea that there are cysts in the ovaries. I mean, it's got, it is surprising, in my opinion, that we still call it by this name. But anyway, it is primarily a hormonal condition, and this summary of the hormonal status in true polycystic ovarian syndrome is a deficiency of the hormone FSH and often an elevation of other hormones, which would include things like insulin or LH, which is luteinizing hormone, an increase in a hormone called anti-Mullerian hormone, which is a hormone expressed by the egg follicles, and some other chemicals. So you can have disturbances of the male, the androgen hormones, this type of thing. So, but the essence is an FSH deficiency, and to some degree an estrogen deficiency, which is related to, in some cases, ovulatory disorders and not falling pregnant. So yes, it is a hormonal condition at its base.
Okay. And then if my mom has PCOS, what are the chances that I do? How would I check whether I have it or not?
Yeah, that's a really excellent question, because one of the, we know that there's probably a genetic component to polycystic ovarian syndrome, although there's no single gene that's been associated. There are multiple genes that have been associated in studies that look at or what are known as gene association studies. But polycystic ovarian syndrome is thought to be, and it sounds strange that we still are trying to figure out what the underlying cause is, thought to be what we call an epigenetic condition. In other words, it's a condition that is programmed in the womb during development. So that relationship between mother carrying baby and subsequently developing polycystic ovarian syndrome is an intimate one. So it is very much related to mother, daughter, and onwards, as epigenetic conditions pass through generations. Diagnosis is I wouldn't go looking for it, is my opinion, because unless somebody's got symptoms, it doesn't mean anything. It would be meaningful if there is a disturbance that is important, such as a fertility issue, or the periods are not coming, or whatever it might be. But one would not really go looking for it to diagnose a condition because there's a history. If there's no expressed symptoms, then one doesn't really need to go any further, and that's fine. Plus, people tend to grow out of the changes associated with polycystic ovarian syndrome, and the severity varies with different individuals. So again, it's not a static condition. It's a condition that may or may not arise, and if it does, it has a history that involves generally effectively growing out of it.
Excellent, thank you. And then number 5, how do you cure PCOS to enable me to conceive?
Yeah, I think the word cure is a word that I would, the word cure is best used for a musical band, The Cure, as opposed to curing the condition of polycystic ovarian syndrome. I think we more manage the condition, and managing of the condition is basically trying to address the mechanisms, some of which I touched on. So for example, if somebody's got a raised insulin level, then we will try to introduce measures that will reduce the insulin level. Might be using medication to do that. People might be familiar with something called metformin. We may use supplements that would do that, which include things like inositol, coenzyme Q10, mixed vitamins. We may introduce dietary and lifestyle interventions, which are hugely important to try and manage it, to sort of affect things in that way. If somebody's not ovulating, then we will introduce measures to get them ovulating. So we might give them medications that stimulate ovulation. They could be oral medications, or we might even use FSH, because I said to you earlier that FSH was a deficient hormone, so effectively we want to bump up the FSH level and get ovulation going, so we might do that. So the idea is to manage all the aspects and at the same time concentrate on the factors, again going back to lifestyle, that are manageable, that decrease the expression of the condition, if I can put it that way. Because, for example, weight management and exercise and stress management and all of these sorts of things have an impact on cellular function and are very, very powerful. So I would more describe it as being a management of the condition. And we must remember that not everybody with polycystic ovarian syndrome, for example, either is seeking the outcome of having a baby and getting pregnant, or some of them may not have fertility issues, but they may have issues specific to the hormonal changes. For example, excess male hormone levels that are causing problems with skin and hair and various other things. So it very much depends on what the reasons you're treating it are, and one would describe it as a multimodal management. And that management includes not just the medical side, but also the mental side. I mean, there's a huge stress component that might involve needing to have psychological counseling. So lots of different specialties within the medical field might be involved in managing the condition as opposed to curing the condition. Okay,
great, thank you. And another PCOS question. When trying to conceive with PCOS and having irregular periods, or amenorrhea, if I pronounced that correctly, what can be done or taken to get them back to normal with the idea of falling pregnant?
Yeah, so to be honest, I've obviously answered quite a lot of that in a previous question, and primarily it goes back to looking at what the specific disturbances are for an individual, including the hormone profiles that we've measured through doing blood tests, and then obviously the individual lifestyle components, for example, examining diet, examining exercise programs, examining stress management, weight management, all of these sorts of things. And sometimes by managing all of these aspects, we may get a spontaneous resolution of the regular cycle. And in fact, over time, that's most likely to happen, but not necessarily in the time frame that somebody wants to fall pregnant, but over many years, it's kind of self-correcting. And then obviously, where, again, depending on the individual circumstances, we may add in specific medicines to induce ovulation. So a very common first-line treatment might be to use a medication like letrozole or clomiphene citrate, which are oral medications that induce ovulation specifically, or we may use the FSH direct stimulation in conjunction with that correction. So you kind of want to optimize everything you can first, and then following on from your optimization, move on to specific interventions. I think a mistake is to use interventions before you've actually sorted out the underlying problems, because you'll get less effective treatment. This is very common across the board. A lot of what we do is gathering a detailed history, examining all the factors that are important, correcting everything that we can do, optimizing where we can, and then we can worry about a specific treatment, as opposed to just jumping straight into the use of a drug or an intervention operatively, or whatever it might be. But that would kind of be the aim of getting somebody pregnant, restoring ovulation, basically.
Thank you. Okay, now, next one, number 7. What is luteal phase defect? How do I know whether I have it?
Yeah, my first reaction would be to say, I have no idea, but I'm not going, that's a slightly frivolous answer, because I think it's very controversial. This idea that there is a primary defect called luteal defect is really very, very questionable. A luteal defect is really describing an inefficiency of the ovulated follicle, to produce adequate hormone levels to support a pregnancy, so primarily progesterone. But in reality, this inadequate activity of the corpus luteum is very often secondary. It's because there is an underlying problem with either the efficiency of ovulation, or there is an underlying condition that's affecting ovulation, or there is an underlying condition of the egg numbers or the egg quality, or whatever it might be. So this idea that people have a primary inability to secrete enough progesterone to support a pregnancy, and therefore by giving them progesterone you will increase the success rate, is first of all intellectually flawed, but I think also quite controversial. I think that most publications and the history of this whole idea are that there is not really a primary corpus luteal defect, but there are other factors that influence the functioning. So again, going back to what I've said in earlier questions, a lot of the management is actually to sort out the problem that's causing the inefficiency of the ovulation in the first place. So that might be by optimizations we've already talked about just generally, along with controlling the ovulation process, and then optionally, if you want to add in things like progesterone supplements and all the rest of it, might help. But there are very commonly we see a hormone supplement being given for a condition, and most of the mechanisms in the body are negative feedback. So now if you add a drug or a hormone into the mix, that has a ripple effect that suppresses other things. And sometimes you might, and a very classic example of this is using estrogen supplementation to thicken the endometrial lining in an ovulatory cycle, which has the secondary effect of suppressing ovulation. So effectively you decrease the chance of achieving what you want to achieve, to have a thicker endometrium. And same with progesterone. So progesterone is sometimes used as a support in very specific situations, but if you look at the data, the idea of progesterone support to reverse a corpus luteal defect is lacking, and rather one wants to sort out the primary issue, which is probably something else, rather than assuming that a corpus luteal defect in itself is primary. I may not have made that very clear, but the bottom line is usually you want to look a little bit wider, a little bit deeper, and just kind of sit down and go through the story to find out what's really going on.
Yeah, no, that was very interesting. Thank you. Okay, number 8. I'd like to know if there's any chance that I can do IVF. I'm 38, in early menopause, and I don't have any children. What are my options?
Yeah, so I guess the key here is really, what does it mean by early menopause? Menopause by definition means there's no periods, which means the ovaries have stopped working, which means there's no ovulation, which means there's no eggs, which means we have a problem from one of the aspects of getting pregnant. So if somebody is in a perimenopausal state, i.e. they still have ovulatory function, there may be enough function to salvage some form of, sort of access to the ovaries to still get an egg or two or not. So if we're talking truly about menopause, and again, I don't, early menopause is either menopause or not, so I don't actually know what it means by early menopause. Early menopause, I assume by age, that's probably what it means, as opposed to the early in the process of menopause. So sorry, I'm nitpicking here, but early as in the stage of age. If it's a true menopause at 38, then in reality, yes, IVF is a very viable option, but it would probably involve having to access eggs that are donated from another person in order to create the embryos to put inside the womb. So yes, in summary, probably with donated eggs, but very much worth pursuing fertility options if one is open to that.
Thank you. Then number 9, besides IVF, what other options do I have if I have blocked tubes? Because myself and my partner can't afford IVF.
Yeah, look, this is a really difficult one, because at the end of the day, blocked tubes are one of the absolute indications for IVF, because the whole sort of theory of IVF is that you are effectively extracting the eggs, fertilizing them on the outside of the body, and then you can control placing embryos back into the womb, so we don't need the function of the tubes. So unfortunately, if the tubes are blocked and the eggs are not getting through, there are no other specific medical interventions in that individual that is going to increase the likelihood of the sperm and the tube getting together. It would have to be some form of assisted reproductive treatment, of which IVF is the mainstay. So I guess one is now thinking of having to consider options outside of one's own children, which is a difficult one. But one would certainly need to start looking at things like adoption and various other things. It would be very difficult to advise and to offer hope of a treatment, because in theory, and this is across the board, there are really only 3 ways to fall pregnant. There's either spontaneous conception, there's conception through artificial insemination, which is a form of spontaneous conception or natural conception, and in vitro fertilization. Medically, we don't have any other ways of getting people pregnant, and therefore sometimes we have to look a little bit outside of that and consider measures such as adopting a child, which is obviously a very noble and hugely beneficial thing to do, but it might not be. It needs a lot of counseling and discussion and proper kind of processes rather than just, jumping in there. But yeah, it's a very difficult one, unfortunately.
Exactly, and unless they happen to be lucky enough to live within range of a public facility that offers fertility treatment. So out of the 3
that would be one way, is finding
if they're in Cape Town or Joburg or Pretoria or
yeah, that's true. That's true. And then the other thing, which I suppose is, which I haven't mentioned, and just while I'm thinking and discussing this, would be the idea of things like embryo adoption. So adoption doesn't have to be adopting a baby, but it could be such thing as an embryo adoption, whereby there might be somebody who's given up embryos that are available for adoption, and those embryos can be placed into the into the womb. So you still manage to carry your own baby, but you've kind of adopted an embryo, and that's something which, and sometimes that can be arranged at, very well. I mean, the costs are very much lower than the IVF process, and maybe a very realistic option as well. And it's certainly worth asking clinics whether they have embryos available for adoption, because certainly they, we go through phases where we do have embryos available for adoption, and that this would be a classic. So, adoption doesn't necessarily mean beyond that.
Perfect, thank you. Okay, number 10, can I conceive with fibroids?
I mean, the answer is yes. So, but obviously fibroids fibroids are a condition of the uterus whereby there are these growths, these benign growths in the wall of the womb, and they take on many forms. You can have fibroids that are affecting fertility. In other words, they are growing in a position in the womb that might have an impact on the ability of somebody to implant an embryo, whether it be a natural conception or any other conception. So these would be fibroids that are either inside the uterine cavity or very close to the uterine cavity. But alternatively, one could have fibroids that are very superficial and that they have no relation to the cavity. And we know very well that, I'm not sure exactly what the figures are, but the vast majority of people probably fall pregnant naturally and didn't even know they have fibroids, and will present in pregnancy, and the fibroids are diagnosed at that point. And obviously in the fertility world, we see a lot of people who present and we happen to find fibroids as a potential contributing factor. So they need to be assessed properly. They need to be given quality information to say, well, these fibroids are within the criteria that might have some impact, and therefore one chooses to address them or not. But in many cases, there are maybe fibroids that are incidentally there, and certainly conception is very common with fibroids.
Thank you. Okay, so now we've touched on this a little bit, but is it possible to get pregnant without a period? And if so, how is it possible?
Again, a very simple answer, yes. First of all, not having a period is the commonest cause of, being pregnant is the commonest cause of not having a period. So if somebody doesn't have a period, doing a pregnancy test is a very sensible thing to do. But the idea that you have to menstruate in order to prove an ovulatory process is not necessarily true. And there'll be plenty of women who will have fallen pregnant and thought, well, I don't remember having my period on time, whatever it might be. Or they might have been taking medication. So for example, a person who falls pregnant, and they may even not be wanting to fall pregnant, might be on the pill or something, and they've not had a period, this type of thing. So the answer is yes, you can. I mean, a period is a reference point for certain happenings in the cycle, but a period, a uterine bleed is not necessarily a period, and the lack of is also not necessarily related to the fact that ovulation and things might not be happening underneath. There are certain thresholds, things that need to happen, and certainly stranger things happen than not having a period and falling pregnant. So, bottom line is it can happen. If somebody is not having a period for a very long time and they are not pregnant, clearly there's a problem, and therefore you would not want to sit back and say, well, I'm not having periods, and but doctors told me I can fall pregnant. It needs to be sorted out. So I'm really addressing the fact that it happens, but not having a period for a long time, in the absence of not wanting to have a period for a long time, or a medical intervention that is stopping you having a period for a long time, is a very good reason to to seek assistance, basically.
Thank you. And the final question, I mean, you've already answered this one with the previous blocked tubes one, but I'm just going to read it out because it has been put to us. So my question is about blocked tubes. Mine are blocked, and every gynae I've ever been to never tried any kind of repair or treatment of any sort. Their answer is just to go for IVF, which is such a costly procedure. What other options do I have? So I guess she probably is asking a little bit about, can they be repaired? Can tubes be repaired if they're blocked? Can the blockage be removed? We already have heard about the fact that blocked tubes means you do need to go for IVF. So what do you think about that?
Yeah, so look, it's actually quite a good question because it opens up the idea of what does it mean to have blocked tubes? Now, blocked tubes, we always think of blocked tubes as being absolute. They're blocked. There's no way pregnancy can occur. But we know that if somebody's been sterilized, which means that somebody has purposefully blocked their tubes, about 1% of them are going to have a failed sterilization and fall pregnant as a side effect. So in other words, there is a relative aspect to blockage in some cases. And another bit on that topic is that people who've gone for, what's called a hysterosalpingogram, which is an X-ray to assess the blockage or not of tubes, have a slightly, with certain types of HSG or hysterosalpingogram using certain contrast, actually have a higher pregnancy rate after they've had the procedure than before, because there's some sort of mechanical aspect. So it's always important to know what is blocked tubes. What do blocked tubes mean? So in this day and age, IVF is so much more accessible and cheaper in a way that, and very few gynaes are trained anymore to surgically operate on tubes to reverse blockages, that just from a practical point of view, there aren't too many people that would do a particularly good job if they were to attempt to unblock tubes. But also, there are very strict criteria. If you've got blockage at one end, then it's possible to consider somebody for a tubal procedure. If somebody's got blockage throughout the length of the tube or at both ends, what we call bipolar disease, there's no point in unblocking the tubes because it won't work. So there are quite strict, sort of criteria that need to be assessed before one would consider. But sometimes you do come across, sometimes we might do a procedure and find that there's what we call clubbing, a blockage at the end of the tube, but the rest of the tube looks very normal, and you perform a surgery whereby you open that up and undo the blockage, and it might be successful. But it is less common nowadays, partly because of the increased success of in vitro fertilization and the accessibility, and from a cost point of view, potentially IVF is a more efficient and cost-effective way of falling pregnant. And if you're going to do tubal surgery, it's a very specific type of surgery that, and to be honest, I was involved in the early days of fertility, when I started training, of being in a unit where they primarily did tubal surgery, and these people were very, very highly trained, and I have not come across many people since who are trained to that level. So it's all very well to do an operation, but unless you are trained to operate in a way that's going to get the results, then one might not want to pursue that route anyway. So it's a very good question.
Well, that brings us to the end of our questions. See?
Okay.
So thank you so much. That was a very interesting conversation. So I'd like to thank you personally, but also to thank Medfem for your constant support of AFASA and all of our initiatives. You're always willing to help us out whenever we ask for some input, so I do appreciate that. And then also to the people watching, I want them to make sure that they follow Medfem on Facebook and Instagram to keep up to date with everything fertility related that is posted on there. The pages are very interesting and they're kept up to date, so it's worth a follow for sure.
Well, I would like to thank you too, and obviously also thank the role of AFASA in terms of support and what you do, because it's a very important part for everybody involved, from the medical fraternity through to the patient side. So, yeah, thank you for asking me to answer the questions. I hope it's been of some help, and everyone out there, I wish them all the very best in pursuing a successful outcome.
Perfect. Thank you, Dr. Clark.
Pleasure.